Rich countries stand accused of not sharing COVID-19 vaccines with poorer nations. And the WHO calls that a catastrophic moral failure. But as coronavirus continues to spread, who will ensure a fair distribution of the available doses? This is Inside Story. Hello and welcome to the programme. I'm Kim Vinnell. Millions of coronavirus vaccines have been administered in wealthy countries, while in one of the world's poorest, Guinea, only 25 doses have been given. The Global Vaccine Sharing Fund, Covax, says it's preparing to deliver its first supplies in February, but is competing with nations striking their own lucrative deals with manufacturers to secure the majority of doses. The head of the World Health Organization has warned the world is on the brink of a catastrophic moral failure, which will cost many more lives.
More than 39 million doses of vaccine have now been administered in at least 49 higher-income countries. Just 25 doses have been given in one lowest-income country. Not 25 million. Not 25,000, just 25. I need to be blunt. The world is on the brink of a catastrophic moral failure. And the price of this failure will be paid with lives and livelihoods in the world's poorest countries.
Now, with a more infectious variant of the virus identified last month, the scramble for vaccines among countries who can afford them has only intensified. The World Health Organization's Pandemic Review Panel co-chair and former Liberian President, Ellen Johnson-Sirleaf, expressed disappointment in the vaccine rollout plans, which she said means shots won't be widely available across Africa until 2022 or even 2023. She says it's no exaggeration to say that we are at risk of creating a distribution system grounded in inequity. We're going to go to our guests just in a moment, but first let's take a look at how many people have been vaccinated so far. More than 46.2 million doses in 51 countries have been administered. That's according to data collected by Bloomberg. Israel has vaccinated the most people per capita, with more than 1 in 4 Israelis having received a dose of the Pfizer-BioNTech formula. It's followed by the UAE and Bahrain. In the UK, just over 6% of the population of 66 million have received a vaccine shot. In the United States, it's more than 4%. Guinea is the sole low-income country to have delivered any shots at all so far, last week providing doses of the Russian Sputnik vaccine to only 25 people, and that's including the president. Well, joining me now are our guests. In Rabat, Azeddine Ibrahimi, Director of Medbiotech, a medical biotechnology laboratory. He's also Professor of Medical Biotechnology at University Mohammed V. In Oxford, we have Dr. Julian Savulescu, Professor of Practical Ethics at the University of Oxford and Co-Director of the Wellcome Centre for Ethics and Humanity. And in New Delhi, we have Ramanan Laxminarayan, an epidemiologist and senior research scholar and lecturer at Princeton University. A very warm welcome to you all. Thank you for joining us on Inside Story. I'd like to start with you, Mr. Savulescu. Dr. Tedros, we heard there, said that the world is on a brink of a catastrophic moral failure. The price of this failure, he says, will be paid with the lives and livelihoods in the world's poorest countries. Is that a fair assessment, in your opinion?
Well, I think that it could be an outcome. I think the WHO is certainly correct to say it would be a catastrophic moral failure to waste or dispose of very viable and valuable vaccine. But I think we also need to understand why this apparent stockpile has occurred in developed countries. And that's for several reasons. First of all, these were pre-approval purchases before we knew which vaccines were going to be effective, when they were going to be approved, and how long the vaccines would be effective for. And that kind of financing was also necessary to bring vaccines to market. So although it appears that countries will have 3 times as much vaccine as their population needs, in my view, there's still space for those countries to donate to Covax excess vaccine once they've met their country's requirements.
Okay, Mr. Laxmin Narayan, there were fears when vaccines came, rich countries who had pre-booked those vaccines, they would be ready, while low-income countries would be made to wait for basically whatever is left over. Is that what's happening now?
Well, keep in mind that, as the other panelists just said, these were vaccines that were pre-booked, and many of the developing countries were really waiting for the Covax facility to be the source for them to procure vaccines. And certainly the first orders will go to those who have pre-booked. The other part of the story of inequity of distribution is simply that, a lot of the vaccines that are getting out of the Moderna and the Pfizer mRNA vaccines, which are stored at very low temperatures, there are simply not the facilities to deliver these in low and middle income countries at the current time. So it isn't as if all of the vaccine is feasible for these countries. There's only a subset that there is. And there will be more vaccines that get developed over, and get approved over the next few months. So I think it's still a little bit of early days with respect to, saying that there's huge inequity. There is, but because systems are in place in some of these countries and they're not in other countries. India would be an example of a country which is a low middle income country, but which I anticipate will see vastly more coverage, both in numbers, but perhaps even in percentage terms very soon, just because India's made that investment in the vaccine scale-up.
And India also has the manufacturing capacity, right? It already had that infrastructure there. I'd like to bring in Mr. Ibrahimi. We heard there from our earlier panelist talking about Covax. I want to ask you, does Covax have the capacity to meet the needs of low middle-income countries? And what happens the longer that those countries have to wait? What does that mean for the virus's ability to mutate?
Well, actually, Kim, thank you for the invitation, but I think I'll have to go back to the numbers. There's no way I will not listen to the numbers. 40 millions for the richest country or the country manufacturing the vaccine, and 25. It's amazing. I'm shocked. I'm shocked and angry, actually. I think we can give any excuses we want to, but I think there is no excuse not actually to share. I think I have no excuse. You can give me that they were pre-booked, they were buying it, they paid for it, they developed it. There is no need that Canada can have 5 times more what it needs. There is no need for Europe or for America to get 5 times, 3 times what they need. I think that's really shocking to me. I think the virus was more human than humans, actually, because the virus actually was very democratic and didn't make a difference between poor and rich country. And here we are taking a distinction between poor and rich country. And I think even the strategy is wrong, because I think, and that's coming back to your question, because even though you will leave Africa with its virus, the virus will multiply, the virus will get its variant, and even if you vaccine your rich country, maybe in globalized world, you will be having a new variant come into your place. So I think the strategy would have been a more human one. It just, as we were into it as humans, coming out of it as humans by saying we save lives of people at risk.
Mr. Ibrahimi, I want to pick up on something you said. You mentioned Canada having 5 times its supply. So I think you're referring to the fact that it's been figured out that if all of the vaccines that are in clinical trials were approved, then Canada would be able to vaccinate its population 5 times over. But can you really blame Canada for wanting to cover its bases?
But now they covered their bases. Now, without that, all the vaccines are good. There is no way that you can just keep them. I can understand that in the beginning you didn't know which one will be working. But now, by December, lots of countries knew which vaccine will be working. And I think right now, there is no need to pile up. What you have to do is just as saying to yourself, as humans, not anything else, not as a scientist. I'm not talking as a scientist. I don't want to talk as a scientist. As humans, as I am really caring for my older people, as I am caring for people with morbidity in my country, I want to save people in other countries. And after that, the second step will be going to the general, the immunity, the herd immunity, or the global immunity. There is 2 steps to any mass vaccination: protecting people at risk. And after we'll come to the next step, to the epidemiology step.
I want to talk about the business of vaccines, the economy of vaccines. Mr. Lakshminarayan, how much money are drug companies really making from these vaccines? I see Johnson & Johnson and AstraZeneca have pledged to sell the vaccine at a cost that only just covers their costs. So who is making money here?
So I think that, it's going to be highly inequitable because, there are 150 teams, many pharmaceutical companies, but the first few developers will have an advantage because they can charge a higher price. And the people who come afterwards both have more expensive trials because they'll have to show that vaccine works against, existing vaccines. You can't do placebo trials, probably not for much longer. And the other part is, of course, just market advantage. But to get to the point about, what the fair way to do this would be, I think I would absolutely agree with the other panelists that the fair way to do it would be that you identify people at risk globally, wherever they might be, and make sure that they are the ones that are prioritized. And this is really what Covax seeks to do. And I believe that we are still having a conversation which is in early days. India, which makes a lot of the world's vaccines, biggest vaccine manufacturer, has literally started vaccinating only 2 days ago. I think it's a bit early to say that this works or that doesn't work. Let's give it a couple of months. I'm sure there'll be other glitches that come along the way. There'll be things that are unanticipated with the vaccines, and certainly not all the vaccines are going to work, as you correctly said. Canada is not going to have 5 times the number of vaccine, and nor will Canada want to vaccinate its population 5 times over. I would imagine that Canada would forego of the remainder vaccines for other countries, and they're certainly not going to build up multi-year stockpiles. I highly doubt that's going to be the case. But I do think that WHO, should go beyond just calling out the problem, which is a good first step. But I think they should also figure out mechanisms to help the poorer countries also figure out how to prioritize, how to get ready. And there are countries like India, which are now already shipping vaccines to other countries, in spite of there being a massive need in India. And I believe the Russians have done it and the Chinese have done it as well. So it isn't as if all the vaccines have only gone to the countries in which they're being manufactured either. So I think it's still a bit of early days, and we certainly have work ahead to make sure it's equitable. But we also need to think about what that equity really means. And I also agree with this point that I think globally, you vaccinate first people who are at voluntary risk, which is healthcare workers, next at involuntary risk, which is people who are elderly or have comorbidities, and then you get to everyone else to seek herd immunity. And I think that should apply throughout the world.
We're going to talk about that a little bit later. I want to come back to you, Dr. Savulescu. You are a professor of practical ethics. I want to talk about the ethics of Covax, as we've been hearing, was set up to give that bloc a better chance at negotiating prices with the drug companies who make the vaccines. In the face of a global pandemic, one must question that entire setup, right? That drug companies would be able to extort countries when the fate of the world is at stake.
Well, in an ideal world, we would have a world government that distributed the vaccine according to ethical principles around the world. WHO is not a world government. We have nations and we have markets, and Covax is a fantastic initiative that runs in parallel with those. But we have to live with the world that we have. Covax has made some strides to get 500 million doses or courses ready for 2021. It's aiming for 2 billion. And the market in some ways has worked. The Oxford AstraZeneca vaccine, 2 billion doses have been provided to Covax. Those are being also provided at cost. India is producing that vaccine at scale. Russia has contributed 1.5 billion doses. China another several hundred million. So countries are attending to the needs of less developed countries. It could be better, and Covax could have more bite, and they're certainly correct to put pressure on other countries. But these vaccines are developed through a market, and that is the reality of the world. And we have to work with that, not against it.
When you talk about doses being donated, do you think that's really out of the goodness of the hearts of these countries, or is this an opportunity to exercise soft power?
Well, I mean, to be honest with you, there's this huge self-interest for rich countries to ensure global coverage because, this pandemics see no country boundaries. If there's a reservoir in one part of the world, it will move to the other part of the world. So, this is something where, self-interest will align to some degree with ethics. I don't think it's purely, though, out of self-interest. I think there are genuine ethical concerns to ensure that the people who need the vaccine get it. I don't think it's about exercising power, at least not in the Oxford-AstraZeneca case. Perhaps China and Russia are seeing opportunities for regional influence. But at the end of the day, we want the vaccine to get to as many people as quickly as possible.
Mr. Ibrahimi, we talk about, everyone is trying to roll out this vaccine so quickly as they can. But might this actually be an ongoing issue? Because we don't know how long immunity lasts for. So might it be that we're going to have this problem every year?
Well, I think there is lots of data showing actually that the immunity will be lasting quite a bit. Actually, there is two papers that one of them came in November in California and the other one in Britain, which showed actually people with the natural immunity actually when they get affected by the virus kept the immunity for at least 8 months. So I think there is probably case that the immunity is for longer period. For the vaccine, actually, I think there is two vaccines actually they showed for the period of the vaccination. They got 3 months. And I think the class or the family of the coronavirus is pretty stable kind of. And with the SARS-CoV-1, actually, lots of people kept the immunity for years. But I would like to jump back to the situation of the poor countries. I think we have to autocritic what we are doing. I think we didn't support the WHO enough, actually, between the bickering between China and the US. I think poor countries and developing countries should have jumped in and say, you can actually, in the UNESCO, have problems, but you cannot have it with WHO because it's a matter of life for a lot of people in poor countries. The second point, and I think for the marketing point, I think what's going to happen is that these countries will come back to the HIV and AIDS situation. We will not recognize anymore the patent rule. For a simple reason, I cannot protect, a company against the health of the population. And what happened in South Africa, for example, breaking the rules of the patent, and maybe will be coming back soon to hunt these companies. They are not willing, or countries not willing to share their vaccines.
Okay, I want to talk about the WHO. Ramanam Laxminarayan. You brought up the WHO earlier. Does the situation we're in now call into question for you at all the leadership or the effectiveness of the World Health Organization? You remember at the time, as we were watching the virus spread, there was a lot of pressure on the WHO to declare this a pandemic, and it held off. Do you think there should be questions about the WHO's handling?
Well, there should always be questions about how WHO performs because WHO is accountable to all of the member countries. And remember that WHO operates within the UN system, but the head of the WHO is actually elected by the World Health Assembly, which is made up of the ministers of health of all of the countries that are part of this World Health Assembly. And I think there will be a calling to account without question. There already is an examination of what actually went on in the conversation between WHO and China back in January itself. And there are important questions that remain to be answered. But at the same time, WHO is a severely depleted organization and is a shadow of what it was 20 years ago. I've been working with WHO for many years, as I'm sure my fellow panelists have been. And the lack of funding of WHO, the deprioritization, but also WHO itself being unable or unwilling to undertake significant reforms, which again come back to the World Health Assembly because it's this whole bunch of countries, that unless the world decides that it wants a strong, effective, and a nimble WHO, it will not get it. And at the end of the day, there's no point pointing fingers at this one organization. This organization reflects the dysfunctionality of global governance of institutions writ large. And the first step, which I'm looking forward to, tomorrow, is when, hopefully, as President Biden had promised, the U.S. will rejoin WHO, and that will sort of bring us to a sense of stability that we recognize that the world solves problems together, not by an America first or some other country first kind of an approach.
Dr. Savulescu, what do you think we can learn from past global pandemics when vaccines took a longer time to get to some countries as opposed to others? What lessons should we have learned?
Well, I mean, the first lesson is we are all in this together. This is, a global problem that we can't just close the door of our country and expect not to be affected by it. So we do need a global approach, and it is a challenge to achieve that. But I think we are making some headway into it. The other thing I think is that, if you look at the eradication of smallpox, you needed extraordinary coordination and indeed in some cases mandatory measures to achieve the eradication of smallpox. Now, COVID-19 is not smallpox. I think it won't be eradicated. It will be more like flu, that it will mutate, we will need to be revaccinated, and we'll need to learn to live with it. So in some ways, I think we need to learn from how we've managed flu pandemics to look at how we can manage COVID-19. But at least in the short term, it may be that we need mandatory measures and we need much greater global coordination.
Mr. Azeddine Ibrahimi, I want to ask you what you make of China's approach, vaccinating its working population to get them back to work first. And what do you think would be the best approach? I know it's obviously varied across the continent, but what would be the best approach for Africa?
Well, Africa, I think we have to make a statement that the African Union is a failure, actually. That's a big thing. How come more than 54 countries couldn't actually manage to have one vaccine developed or produce a vaccine? I think we have to critique ourselves, but the African Union, at least as a voting bloc in a lot of institutions, could have worked a role actually in bringing vaccine, but we don't see anything actually in Africa. I think the way to do it, I think it's we have no leverage, and that's the reality of things. We have no leverage against either the rich countries, either the manufacturing countries like India and China. And if China basically or Russia want to play geopolitics with the vaccine, it will be tough to do to actually counter them. The only way that we could do it actually is to help ourselves. And in the next time, we'll be ready to develop drugs, develop vaccine in Africa without needing to actually rely on other countries.
Dr. Savulescu, do you think governments will spend more seriously now on pandemic preparedness?
Well, to be honest, it's very fortunate that COVID-19 is not as lethal as Spanish influenza. So, on a long-term scale, this is not one of the worst pandemics that we've had. So we are going to get worse pandemics than this. And we also have the possibility of bioweapons, intentionally constructed biological weapons, which are very easy to manufacture. And if Ebola was bioengineered to be as contagious as COVID-19, it would be a total catastrophe. So, and those events, are possible. In a backyard laboratory, you can create a virus capable of wiping out not, millions, but hundreds of millions of people. So we need to radically rethink our preparedness for pandemics. This is one of the greatest existential threats, not COVID-19, but a future pandemic. And we were totally ill prepared with the preparation of PPE or personal protective equipment. We've been able to develop a vaccine in a year, but we still don't understand the disease. We need to rethink doing challenge studies to rapidly develop understanding of disease and more rapidly develop vaccines.
I think we'll be digesting this for a very very, very long time. We'll have to leave it there for time. Thank you to all of our guests. Azeddine Ibrahimi, Julian Savulescu and Ramanan Lakshmi Narayan. And thank you too for watching. And you can see the programme again anytime by visiting our website aljazeera.com. And for further discussion, you can go to our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter. Our handle is @AJ Inside Story. From me, Vinnell, and the whole team here. Bye-bye for now.